I am very excited to introduce our next speaker talking about internal medicine topics and blood cancers, the great Sarah Thomas, or Sarah Thomas Stearns, or some combination of that. Sarah is a senior instructor in the School of Medicine and nurse practitioner in the Division of Hematology. She graduated from James Madison University in 2011 with her bachelor's degree in nursing, worked in the medical ICU as a bedside nurse at the University of Virginia, then went back and got her NP training at University of Virginia, and then came to the lovely University of Colorado and did our hospital medicine fellowship. And then we scooped her up from that into our blood disorder center and hematology group. During her fellowship, she found that passion for malignant heme and came to work for us 5 years ago. She keeps telling me she feels new. She's not new, guys. She's an expert. Ask her lots of hard questions. She also serves as our BDC APP lead counsel and has done remarkable work within our education and onboarding program for our APP team. She enjoys the challenge and complexity of managing internal medicine problems within the blood cancer population. So please join me in welcoming Sarah.
Thanks, Meredith. Can everyone hear me okay? I do still feel very new. There's always new things going on in this field of medicine. So, but anyways, for those of you who've been here on past talks, I always enjoy taking care of these patients for a variety of reasons, but I love internal medicine, but particularly I love how internal medicine is slightly different for our patients with heme malignancies. And so each year I sort of look for a topic that overlaps both, and then like to highlight kind of how that is different for bone marrow transplant patients or heme-onc patients. So this year I thought we'd talk about transplant-associated thrombotic microangiopathy, which is kind of a lot to say. So just for the purposes of this presentation, I'm going to abbreviate with either TA-TMA or TMA, unless otherwise specified. In terms of our objectives, so we'll talk a little bit about the pathophysiology and why that's a little bit complicated. Identify possible underlying risk factors for TA-TMA, and then talk a little bit about the treatments. I have no disclosures. So to start, as a review, TMA basically results from endothelial damage and dysfunction, which then leads to microvascular, arterial, and venous thromboses. The end result of this includes ischemic tissue damage, organ damage, which also manifests in thrombocytopenia and hemolytic anemia. So basically, the occlusion of vessels happens with platelet-rich thrombi and then subsequently leads to your organ damage. It's still unclear as to exactly the pathway in transplant-associated TMA, but we'll talk a little bit more about that. So in non-transplant TMA, this is sort of like, I think of this as an umbrella term, TMA, for this handful of conditions that basically result in TMA, but all occur for different reasons. So in TTP, you have an ADAMTS13 deficiency. You can also have TMA that results from a Shiga toxin-mediated HUS or hemolytic uremic syndrome, which is a direct injury to the epithelial cells in the setting of the Shiga toxin. You can also have drug-induced, whether that's immune or non-immune mediated. Metabolism mediated, which is something like B12 deficiency by means of gene mutations, coagulation mediated, as well as G6PD deficiency. And so when we think about transplant-associated TMA, it sort of falls in the category of an immune-mediated, but not necessarily drug-induced. So it sort of is a little bit of an outlier, but we'll talk a little bit more about that. So just to review, in post-transplant-associated TMA, it is presumed that the complement system plays a huge role in how this develops. And so as a reminder, I know Heather did a great job talking all things immune system. Complement is part of the innate immune system. It really is involved in the maintenance and cell homeostasis. So that's both a pro-inflammatory versus an anti-inflammatory state of the immune system. It clears unwanted materials and cells. It interacts with other pathways and processes, leading to things like the coagulation cascade, the kinin system, communicating with your adaptive immune system and building it, as well as inflammation, as mentioned. So, to talk a little bit about the pathophysiology, in post-transplant associated TMA, there's suspected a precipitating event that activates complement. Complement then leads to this end sort of complement pathway, which is the membrane attack pathway, also called MAC or C5b9 pathway. Each of these sort of cascades occur along the way. So this is the activation of the lectin, classical, and alternative pathways. What then happens is that once this C5b9 pathway is activated, it then leads all of these other cascading sort of activations, which then subsequently lead to more cascading activation of things like cytokine production, immune cell infiltration, and then coagulation cascade. So when this occurs, it then leads to further procoagulation state in the blood and endothelial cells, and then reactivates the complement system. So if you can imagine this getting activated post-transplant, it sort of just continues the cycle and creates somewhat of a snowball effect. And our post-transplant patients by nature really have a strong or perhaps dysregulated immune response in the setting of things like infection, graft versus host disease, et cetera. And some key pieces about this, just to keep in mind as we go along, is that for transplant-associated TMA, it's suspected that all three of those pathways, the lectin, classical, alternative pathways, are activated when this occurs, whereas in other forms of TMA that we mentioned before, they are more likely related to maybe potentially one pathway and not necessarily all of them. Another interesting piece about this that I found out when doing some reviews for this presentation is that the C5b9 in post-transplant patients, just in general, they have a much higher level of this terminal complement level. So we'll talk a little bit more about that too. And you might be asking yourself, well, why does this occur? And I will preface this slide by saying some of the literature calls it a 2-hit hypothesis. Some calls it a 3-hit hypothesis. To me, it seemed like it was a 4-hit hypothesis, but either way, same sort of principle. But what it is, what a lot of the literature says is that there is some sort of underlying pre-existing genetic disposition for patients that leads to endothelial injury, whether it's by the endothelial damaging conditioning regimen or with additional insults such as immune suppressive drugs, viral infections, HLA mismatching, GVH, et cetera. So the 3 hits hypothesis basically explains that one, the patient would have a pre-existing genetic disposition, but then further would have 2 of the 3 of the following hits or injuries. What's really interesting about this is that the question I asked myself was, why then do we not do more genetic testing? And there's a few reasons why that the literature sort of outlines, which was super helpful for me to understand. And that is that, one, it should be done before transplant. The second is that there's really long turnaround times. And the third, perhaps the most complicated piece of it, is that there's really a poor understanding about the genetic variants. There's so many of them, and multiple genetic variants seemingly contribute to the development of this condition. And so when you think about trying to sort of narrow it down, it's basically, at this point, very, very difficult. So to talk a little bit about the incidence, it's very widely reported. Anywhere from 7 to 39% of patients post-stem cell transplant do have some sort of transplant-associated TMA. It really varies by the type of transplant, the type of conditioning regimen, underlying primary diagnosis. And we'll talk a little bit about how this is, the whole sort of topic is a little bit ambiguous for a variety of reasons, but so just to sort of, I'm a visual person, so I like lots of visual diagrams, but transplant-associated TMA involves thrombocytopenia, again, hemolytic anemia, and then some sort of organ dysfunction. What I think is really important to think about with this is that when you take that center circle, you could easily post-transplant substitute it with something like post-transplant complications and explain these symptoms in a variety of different ways for different reasons. So this is just to sort of mirror the fact that, you can have post-transplant thrombocytopenia due to poor graft function, immune suppressive agents, all sorts of things. Same thing with organ damage or anemia. And so it's very important to just sort of keep in mind as we talk about this, that these things can really lay low under the radar, but then can contribute to pretty significant morbidity mortality, which we'll talk about. So some of the clinical features, meaning like, what kinds of things do we typically see when, that might prompt your thinking to think that maybe this is what's happening for this patient, TMA. The first is that it's usually within the first 100 days post-transplant or later. Some of the studies outline that it's a 50-50 percentage. So like if it's going to occur, 50% is before day 100 post-transplant. The other 50% is after day 100. For patients, sometimes they have a sudden requirement for transfusion support post-transplant where they have been grafted and then suddenly they start needing more transfusions. You may have a patient who has hypertension that's very, very much out of proportion of their expected. So they are suddenly requiring more than 2 antihypertensives. And these are systolic blood pressures in the typical like 200s or higher, so very substantial hypertension. You may have unexplained neurologic dysfunction. After a thorough workup, you still cannot quite like pin down why they're having any sort of neurologic changes. They may have organ dysfunction, also otherwise unexplainable. In terms of some of the clinical manifestations, as we kind of talked about the endothelial damage, you can imagine that given the blood vessels are everywhere and all sorts of things, you can imagine all of the different clinical things that can arise from this condition post-transplant. So we talked about hypertension, of course, renal dysfunction. The abdominal and GI symptoms are also related to those microvascular thrombi within the GI tract. You can have things like ascites, headache, as well as further neurological abnormalities. And these can be very like vague, or they can also be very specific. Pulmonary changes, as well as things like pericardial effusions and pleural effusions. Some of the other clinical clues in terms of post-transplant TMA. So for these patients, renal dysfunction is often present. They may have recurrent serositis, so that's like your effusions without perhaps generalized edema. They may have peripheral neuropathy, muscle weakness, hypoxemia. And one of the interesting clues too is for patients who have GVHD or the presence of GVHD, this may be a patient who has refractory GVH, despite high-dose steroids or perhaps multimodal therapies. Additionally, may have GI tract bleeding. In terms of the pulmonary system, I thought it was pretty interesting just thinking about how this would impact it. And there were some case studies that kind of talked about how the development of DAH is also a possibility, diffuse alveolar hemorrhage in patients with TMA post-transplant. And basically, there are the microangiopathic changes within the vascular system of the pulmonary beds, and they lead to increased PA pressures and subsequent RV failure. So you can have lots of different pulmonary results from that. And just in general, the most common a clinical clue is that patients will have renal dysfunction, and then subsequent in order would be GI symptoms, and then followed by the neurological changes. So I was just very curious about how, what kinds of things will either make patients more or less risk for this condition. The first is that it can occur for any age. There's not really a specific age risk for these patients. Certainly donor type plays a part in this. So you can have a mismatch or unrelated donor would make you more likely to develop TMA. You can have patients who undergo myeloablative conditioning regimen. Certainly calcium-urine inhibitors. The use of those is also highly associated with that, and we'll talk a little bit more about that. For graft versus host disease, especially with liver or GI involvement, which definitely puts you more at risk. Patients who have received a prior stem cell transplant, so if they have received whether auto or allogeneic stem cell transplant in the past, it definitely puts you more at risk if you're undergoing a second transplant. Some of the literature defined ALL or those with severe aplastic anemia as being more high risk than others. Certainly, if you have pre-transplant renal dysfunction, you may be more at risk. And then certain types of infections, and the literature sort of outlined a lot of different things, but it came down to the fact that if patients have things like bacteremia, fungal infections, or specifically viral infections, you are more likely to develop this condition. Just a few interesting points about this, and perhaps one of the most important is that pretty universally, the literature mentions that graft versus host disease, or the presence of it, is probably the most important risk factor for developing TMA. And what is interesting is that the donor type or type of stem cell transplant being mismatched or unrelated may not be the actual contributing factor, like the type of transplant doesn't directly lead to TMA. It's more of they are more likely to develop graft versus host disease, and that then leads to TMA, if that makes sense. And basically, there's a lot of different discussion on why these certain things are more likely than others, but it's a very broad range of things that contributes to potential risk of developing this. Okay, so I always like to think about, so if it's not TMA, then what other things could it be? And in our patients, I think for anyone who's cared for them, they know it could be probably pretty much anything. These patients are very, very medically complicated for the most part. So when you think about differentials outside of TMA, you can certainly have TMA unrelated to sort of the pathophysiology we talked about. So not necessarily complement related, but potentially having an ADAM-TS13 deficiency leading to TTP. The presence of graft versus host disease. You can have sinusoidal obstructive syndrome or VOD, BK nephritis, engraftment syndrome. You can have all types of infectious etiologies. It can be a toxicity from your chemotherapy or conditioning regimen or medication toxicity. Psychiatric conditions, delirium, specifically with the pulmonary symptoms, it could be resulting from radiation. And then, of course, acute coronary syndrome. So what's kind of interesting about this is just to keep in mind, so graft versus host disease, especially in the acute setting, does not typically involve the renal or neurologic system. So if you're seeing a patient with renal dysfunction or neurologic dysfunction and you suspect or you're treating them for graft versus host disease, could be something to clue you in on this. It's not typically like patients with graft versus host to have renal or kidney or neurologic dysfunction. When we think about SOS or VOD, one kind of key differentiating factor for patients is that patients with SOS or VOD typically have changes in their bilirubin as well as weight gain and fluid retention. So you may use that as sort of a helpful piece of information to think about if this is truly TMA or not. So I did want to talk a little bit more about this marker of terminal complement activity, this C5b9, which is also a lot to say, sorry, the MAC terminal complement pathway. So it's, again, a marker of terminal complement pathway. So if we ask ourselves, like, why do we not measure this more in patients? And really the big reason why is, one, even if we did, a low normal is not going to exclude TA-TMA. And that is because all of the other stuff could be happening leading up to the terminal activation of complement. And so you could potentially use it as a marker for being very high as a very helpful clinical piece of information. It's often substantially elevated in patients who do have TA-TMA, so it would be helpful if it was markedly elevated. But the literature sort of outlined that there's many technical lab difficulties in measuring. There's very inconsistent information and how they're measured and reported and things like that from even institution to institution. There are some other sort of biomarkers, and I didn't really get too much into detail about them, but basically things like von Willebrand factor, which is a marker also for endothelial dysfunction, can be measured in these patients to sort of help your clinical diagnosis. But there's still a lot of questions that remain behind or around sort of biomarker levels and measurements and things like that. So Why are we talking about this? I think most importantly to think about, this is very life-threatening potentially for patients. It is associated with a lot of morbidity and mortality, so can progress to end-stage renal disease, have multi-organ involvement that can be lifelong. And the mortality rate is widely reported, but can be as high as 50 to 75%. And as I mentioned before, it's very important to remember that these kinds of symptoms can lay low under the radar or be easily explained by other conditions post-transplant, making this something that should be sort of more on our minds, but potentially may not always be the case that that's what's going on. And for some patients, the overall survival rate at 1 year was reported to be 42%. And I will say too, the data in terms of survival rates, mortality rates is very variable based on a variety of different factors. As you guys saw, there's a number of different risk factors. So all the combination of, did the patient have pre-transplant renal disease? Did they have a genetic predisposition? What type of transplant they had? When you start adding all those factors in, it's understandable to believe that all of the rates may be different depending on how the studies looked at things. Most commonly, the cause of death or mortality in these patients is organ failure, specifically renal failure. But what I also found interesting in the literature review for this talk was that there was one single center, smaller but single center study that looked at the amount of patients who were accurately diagnosed at time of onset of the condition. And only 36% of them were identified as having TA-TMA at the time that, I guess, clinically, when they looked back at the patient, did have it. So it's just something just to remind us it can really kind of lay low under the radar. So when we think about treatment, there's a number of different things we can do. So first and foremost, we talked about calcineurin inhibitors, specifically things like tacrolimus is well known to be a common precipitant of TA-TMA. And the first thing is to discontinue the precipitating agent. When you think about this, sirolimus is an exception, and that could be a whole nother discussion. But when you think about discontinuing the precipitating agent, it's important to remember that graft versus host disease is the #1 reason, or presumably the #1 reason why these patients develop TA-TMA. And so they will need some sort of substitution for GVH prevention. Additionally, you can have supportive care, so transfusions, you can manage the hypertension. One literature review talked about using ACE inhibitors or ARBs, but there's not really like a huge preference for one versus the other or any other alternative antihypertensives. If they need dialysis, of course. What I think is probably one of the biggest questions, because when we think about TMA in the traditional internal medicine sort of area, there's a lot of discussion about plasma exchange and how that helps, outcomes, specifically in patients with TA-TMA without an add-on TS13 deficiency, which is very common or more likely. It's unlikely you have both, but plasma exchange does not have any sort of utility based on the literature I reviewed and does not contribute to any improvement in their outcomes. And then certainly treating the underlying infections. Some interesting points about this are, you could say to yourself, well, if I just discontinue the precipitating agent, is this enough? And the answer, at least based on the literature, is no. So you also have to do any sort of combination of these other things, which we'll kind of talk about. The other important piece of information to kind of keep in mind is, given sort of the ambiguity of this somewhat clinical diagnosis, there's not really a clear marker for successful treatment, right? So renal function may get better, but is their neurologic status better? There's a lot of ambiguity on how do we really say this is successful in terms of the treatment. So you can also have things like, you can also use things like rituximab, epilosumab, defibrotide. And I will preface this by saying there's no way I can pronounce some of these drugs. But a lot of them are based on very small, either case studies or single center small trials. And they have been used fairly regularly. I would say rituximab is used pretty regularly. And then we'll talk a little bit more about epilosumab. And in terms of epilosumab, so epilosumab is a monoclonal antibody. Things to keep in mind for this is that because it is a terminal blocker for complement, it is a very, very high risk for these patients to develop meningococcal infections. and they must be vaccinated. What I thought was interesting in the literature I reviewed was that there's no significant difference in potentially fungal or bacterial infection incidence. Another key piece was that the literature did recommend that you have drug level monitoring. However, it's not readily available. So, think about that. And then I also thought this was interesting, is that you do dose adjust to optimal effect, but there's not really an outline of like how exactly you do that, at least based on the studies that I reviewed. So another interesting part about the treatment here, outside of sort of your supportive measures and discontinuing your calcium urine inhibitors, is that you could think about the fact that we talked about the complement pathway, all three pathways being activated in these patients when they have TMA. And there's a lot of discussion about is multimodal therapy is going to be something that's going to be in the future. So blocking different activations of complement versus some of those other more novel complement blockers only block one pathway. So it's trying to preserve the immune function and not completely kind of obliterating their immune function in the process is another sort of interesting topic of conversation. So the response rates for these patients, 25 to 93% of cases. Again, very, very wide range of responses. And that also is variable based on all of the different things we talked about before. So they may vary by treatment type. And it's somewhat not the most narrow in terms of like which treatment is the best and things like that. So just to summarize, TA-TMA is suspected due to complement activation. The onset is likely before 100 days post-transplant, but the studies say it could be 50-50 before or after. There are many risk factors, but perhaps the most important is the presence of GVH. It is presumed to be the highest risk factor. And clinical features of TA-TMA certainly mimic numerous post-transplant complications, so it's easy to miss. There are many treatment options, but there's not enough data to really support one versus the other or any combination of things. And then TA-TMA is associated with significant morbidity and mortality, so early recognition and intervention are essential to outcomes. And I will say, I feel like maybe one of my slides, because I had some diagnostics in here, I'm now realizing. But anyways, we can go back to that if I can find it, sorry. I don't know where it went, but. So sorry. I can take, oh, sorry. I may have switched it too soon. Did I skip over this? I'm sorry, guys. Sorry, just to go through diagnostics really quickly, because I was like, I know I talked about this. There's some key points about this. So in terms of things, if you're suspecting these patients have TA-TMA, first and foremost, CBC with differential will be helpful, right? You're looking for anemia, thrombocytopenia. Peripheral blood smear is looking for schistocytes in the setting of hemolysis. You'll have perhaps a very markedly elevated or elevated LDH with a low haptoglobin. BMP looking at your creatinine. A Coombs test would be negative. UA with urine protein with elevated proteinuria. Your immune suppression agent levels. You can have complement testing as well as your ADAM TS13 activity, just ruling out any alternative causes of this. Serum viral studies are helpful. So a few key pieces about the diagnostics. One, perhaps the two most important things are these patients will almost assuredly have a very elevated LDH with renal dysfunction. And so those two things alone should sort of clue you into this being potentially TMA. Additionally, the presence of urine protein is associated as like an early sign before perhaps renal dysfunction, and is also associated with very, very poor prognosis or severe injury. So really examining the UA is important. And then last, you could consider something like tissue biopsy, for example, like a renal biopsy. But in these patients, a lot of times you can certainly get tissue and it will show that the patient does in fact have TMA, but it will not 100% tell you what the etiology of it is. So if it was related to some of those non-transplant associated etiologies, then certainly the biopsy is not going to be that helpful. Additionally, these patients are often thrombocytopenic, putting them much higher risk for biopsies. And then oftentimes they are non-diagnostic in these patients. So, gosh, sorry about that, guys. I think I must have clicked too fast. Anyways, questions? Yes, Gary. Yes. Yeah. Okay.
So like the I'm Carrie, everybody. Thanks for listening to me babble here. So I have a couple of questions. I work predominantly outpatient, so we don't see a ton of this really. It's probably something that you see more often inpatient. As far as the pace of, patients being fine on Monday, I would imagine that this happens pretty quickly. So if they come back on Thursday for their twice weekly evaluation, at day 60 post-transplant, you might see big changes. Is that true?
Correct. Yeah.
And then my other question, I don't want you to go back to that diagnostic slide, but you mentioned that
Yeah, the C5B9.
Are you drawing that? Are you even bothering to draw that?
So,
or what's your strategy?
Yeah, it's a good question. Like, I personally am kind of more interested in knowing, like, should we be using that more often? Like, what is our institutional ability to do that here at University of Colorado? My inclination would be yes. It's hard to know though, like I was kind of thinking about it if complement, if the levels are just markedly high in post-transplant patients with TMA, is it somewhat non-specific too? Like, could they be elevated for other reasons? And so that was one other big question I had, but I don't know. It was one of the things I wanted to kind of look into is like, should we be doing that for our transplant patients? Should we at least checking maybe pre-levels, post-levels, pre-transplant, post-transplant? And or should we be trending them? I think too, it's somewhat of a very difficult to pin down diagnosis. And so there's a lot of like, should we not? At least based on like all the literature and also talking with one of our transplant attendings too about it. So that's a good question.
Unless somebody else has something, but yes, this is a really important topic, I think, and this is, I think, a scenario for those transplant patients that does oftentimes come on pretty quickly. And, it is something that we want to fix really quickly. Right.
Yes.
And so not only, when you see a patient who assess in the morning who is slightly altered, they're not quite their self, maybe they're creatinine bumped, somewhat significantly overnight, and knowing that, there are a lot of other things on your differential diagnosis that can cause these kinds of symptoms. Kind of what is your thought process? Like, how do you, from the time you assess that patient to the time, you're working through the differential diagnoses to fix it? Kind of what, I just want to, I think the group would kind of like to hear from an experienced provider of how that actually happens.
Yeah, so I actually thought about a lot of patients when I was doing the, a lot of literature review on this, because there were a lot of patients that I was like, I wonder if, this just reminded me that this can be very, very subtle. And so I always thought I kind of thought to myself, there's patients I should have been thinking about this sooner in potentially, but the scenario I kind of think of where this comes up a lot, at least in my mind, is like patients who have these sort of persistent neurologic changes, persistent renal dysfunction, despite the fact that we eliminate nephrotoxins, we hydrate them, try to get rid of all the other underlying etiologies, and then they still kind of persist and don't do the best. My thought is that perhaps this should be a discussion sooner in the differential for these patients, especially seeing how high the mortality rate can be. But it seems like based on my clinical experience and then a lot of the literature is that typically this comes up after we've sort of ruled out everything else, which I think is also good, right? Because infectious things, especially like if you have CNS infections, things like that, are very important to rule out in these patients too. So I think maybe thinking about it sooner is probably the best way, or at least talking about it, and then thinking about like what Carrie mentions, like, should we be checking these levels? Should we be thinking about like gene testing before transplant, thinking about identifying patients who might be higher risk for these things, and sort of thinking about those things too. But this presentation in particular really prompted my thinking to be like, maybe we should be thinking about this sooner and maybe a little differently. But yeah.
I think that's kind of exactly right too. I mean, I think TMA, Transplant Associated TMA, is one of those things that, if you get a little bit too far down the line, they may not have renal recovery, and they can have major, CNS complications and so on from TMA, and the implications of, say, switching tacrolimus to sirolimus and seeing renal recovery, and all of the things that go along with TMA, seeing that recover sooner than somebody who needs epilosumab and rituximab and, all of these very immunosuppressive drugs that are given to a patient that is very immunocompromised to begin with, and this usually does happen, early on in the transplant course when the patients are the most immunocompromised, so I think it's just such a very important topic that can get missed and it can be something that you pick up down the line. So I just think that going back to Meredith's talk, I'll talk about this, the importance of that really good review of systems and physical exam to pick these kind of things up early. I think this is just so important. Really, thank you for highlighting that.
I have one.
Yeah.
Since this kind of is a diagnosis of exclusion, but one that like you can't really wait too long on if we really want better outcomes. Well, first, just like from your experience, I haven't been inpatient a ton recently, but have we recently gotten to the point where like we've actually listed this as a problem on the problem list? Or are you, going back through patients and being like, probably should have been thinking about it here and here and here. And then secondly was like, I wonder about discussions with the physicians, like how much we should be treating empirically if we've ruled out this, and this. Like, I know there are risks to all those drugs, but I mean, in the grand scheme of things, is it better to save their kidneys? They're already super immunosuppressed. What's a little bit more rituximab versus maybe more rituximab is a catastrophic infection? I don't know, but I don't know, that'd be an interesting thought. Cause like for a diagnosis of exclusion to be diagnosed, we take a long time.
Yeah, for sure. And you think about like the amount of broad differentials, and you think about even if the patient just has, and I say just very, not lightly, but has like neurologic dysfunction and renal dysfunction, the amount of differentials in a post-transplant patient just for working up those two things separately is just numerous. I mean, and it could take weeks to really sort of tease out all of that stuff. I certainly think it should be a topic of conversation sooner. One thing I will say is I did talk to one of our transplant attendings about this presentation, and kind of reiterating what we were talking about with the data is that it's such a wide range of severity, clinical presentation, risk factors, and we start adding in all those variables, along with the fact that there's not like a clear treatment, a clear measure for treatment response, it becomes this like really difficult. I can see where some people will be like, well, maybe it's not that, because we have like 1,000 other things we should probably rule out first. And then there's also the fact of like, if you were to use something, I would think about like maybe rituximab being like seemingly lower risk, but like epilosumab for sure seems like a much higher risk in a especially, pre 100 days post-transplant patient because of how it functioned. And they are already going to be so immune suppressed for, a year or more. So it's very interesting. Like I had a lot of the same thoughts, Erin, because I was kind of like, should the discussions about this be a little different? Like, is it harmful to maybe potentially do a little bit of rituximab if we were thinking about this for a patient? And so it's very ambiguous. And definitely our transplant attending was like, yes, please emphasize it's ambiguous. And there's a lot of like different ways you could do it. You could treat it empirically, but it seems like the general sort of principle in the literature I reviewed is that people like either some sort of tissue diagnosis or they've ruled out everything first and then they treat for TMA, which, you know, it's hard to say, not being in those clinical scenarios, like how I would think I would potentially do it. But I think this whole thing in general has really moved this more of to be more of a topic of discussion sooner for post-transplant patients, at least for me.
I would imagine that, you know, we're not there yet, but I bet they're going to find some sort of biomarker for this, like in the next 5 years. And
Yeah.
that's going to be the thing that we're going to be drawing and saying, ah, this
Yeah.
is TMA. Yeah.
Yeah, I was thinking too, because you can use one of the studies I reviewed had like a list of a variety of different biomarkers like von Willebrand factor, because it sort of gives you a direct, you know, it's a measure of endothelial injury. And so some places were like measuring von Willebrand factor amongst like some of the other markers, but they're still not like specific. So they're like, you could trend them, but it's not going to like tell you 100% if that's like what's going on. But I would agree with you, Carrie. I feel like, you know, it's something that potentially in the next who knows amount of time, like we have like a very specific biomarker for, which would be great. So
Find immunosuppressants that don't contribute to this problem too.
yes,
Maybe we use more routinely.
great. Well, thank you guys. Appreciate it.